Thank you very much. I appreciate all the comments from all the presenters in the second panel. At this time, I'd like to open up to any questions for any of the members. I believe Senator Roth had a question.
I was just curious, on one of the slides referring to generic drugs, I think you indicated, I didn't pull it up, but 27% increase between 2012 and 2014, if I have the years right. It was a 2-year period. What accounts for the 27% increase for generic drugs? Has there been some accounting of the price increase? Does it have to do with lawsuits and claims? Certainly it's past the period where there must be cost recovery that's already occurred for the development of the drug.
Yeah, I can't tell you what the reasons are. I can only tell you that it's just over a decade ago, you can count on the generic drugs price not increasing at a rapid rate at all. We're staying very static. Just the entire industry, I think, are just increasing their prices, significantly increasing generics. Now, a lot of the generic manufacturers have been bought and consolidated as well, and that could be driving that. But the generic prices, since, for example, in a lot of the Medi-Cal plans, and I'm sure commercial plans too, we enjoy a very high generic utilization rate due to our utilization control. And so we have up to 90% generic utilization rate, and we've enjoyed, obviously, a good, providing quality care, but maintaining utilization control. But when the generics themselves are increasing unit cost, and, Senator Roth, couldn't tell you what all the reasons behind the price increases are.
Have there been a significant number of mergers? And I guess by that you mean competition has been eliminated, therefore.
I think there's some of that going on. I'm not an expert in this area, so I couldn't pinpoint to the reasons.
And I guess as to the one that increased the price by 2,800%, I guess we can figure that one out.
Right.
Okay. Thank you, Mr. Chair.
Thank you. Anyone else? Senator Pan?
Thank you. Appreciate the presentations. I guess it's been mentioned that we have specialty drugs, and I think those are a situation where there are not a lot of alternatives. At least they're first ones coming out of the gate, maybe 2 or something. But I am curious about sort of following up on both generic medications. There are multiple potential manufacturers. We know we've had supply issues as well. Methotrexate, I think, was in short supply. Certainly, I think we'll hear from the manufacturers themselves a little later. But I am curious from perspective as payers. On one hand, we've had sporadic supply issues with some pharmaceuticals related to that have been around for a long time, and then you're also seeing these swings, and one would say that in most other products, if you have multiple competitors and so forth, you have you negotiate between them and you try to bring the price down. Where is the appropriate spot then? Let's move specialty drugs out of the way for right now. But in terms of assuring we have a reliable supply of pharmaceuticals like methotrexate or others, and yet at the same time, in terms of managing costs, I mean, just find this sort of an odd juxtaposition that we're talking about, particularly when it pertains to whether it's in terms of generics or drugs have been around for a while, right? Why so? And I guess anyone.
About it, but I won't say I'm an expert, but often, as you notice, sometimes there are limited producers of the drug, so sometimes it's down to one single one or a couple, and sometimes it's just because they can. You've seen the articles on simple things like erythromycin and doxycycline, which we used to use for treating acne and things, which were $20 a prescription. They increase it to hundreds of dollars or thousands of dollars, and it's just because some of them can, and we're pretty much stuck. I mean, we can't really import these drugs from other companies, from other places in the world, which many of these other products you can. As you can see, TVs and cars and things come from many other places, and we often don't even get them across the border from Canada.
So I guess usually in the market, if someone's making out with a lot of money, someone else enters the market. I realize we have patent issues with, and so and again, maybe this is not the question for this group, but I just it's what's going on then why doesn't someone else just enter the market? And if someone else is making so much money off of doxycycline, which is now no longer under patent, why didn't someone else come in and manufacture it for a little less and make, take some of that share away, and then now, I mean, that's usually how the market's supposed to work, right?
Yeah, and I don't have any solutions either. But I can tell you, sort of add to that example, there are two insulins that I'm going to take an example of. Lantus, made by Sanofi, and Levemir, made by Novo Nordisk. Both of them increase in price exactly on the same day by 20%. On May 30th, 2014, both of them raised their price by 20%. And there's, as you know, interchangeable insulins.
Do you have a response?
Senator Pan, as a purchaser, I just want to be able to validate that we have also seen an uptick in the unit costs of generics. Now, I can't explain to you the rationale behind that uptick, but just to confirm that it is happening, we are also seeing that in our pricing as well.
Yeah, Senator Roth?
Just a follow-up, I'm just curious, is there Justice Department activity on that particular case that you cited?
I'm not aware.
Seems to me that ought to be a fertile ground.
Thank you. Any other comments or questions from any of the other members? I have a couple questions. First one would be directed to Ms. Cantwell from DHCS. I understand that, and this is regarding the $300 million that the governor's put in his budget, the $100 million for last year, $200 million scoring for this next cycle, that for Medi-Cal, it's for prisons, Office of AIDS, and for Medi-Cal patients, but does it also include the kickback payments that the state is already providing to the Medi-Cal managed care plans outside of their capitation payment as well, or not?
It doesn't. So we have a separate budgeted item, and I apologize, I don't have the number with me, but it is in our Medi-Cal estimate what we projected our costs would be based on our structure of the kick payment. But we knew that there were further drugs in the pipeline, and so in discussions with the rest of the administration, sort of recognizing that we made that estimate in November with the drugs that were sort of out at that time, and sort of acknowledging that we didn't really know what the scope would be, how many patients would be receiving it. So there is separate funding already in the Medi-Cal budget, but the governor put that in sort of more broadly to sort of look at what the potential cost might be. And as you know, the administration is convening a work group to really look at that and look at how we utilize those drugs across the state.
Okay, so for the $300 million estimated to meet, is this going to be estimated to meet the demand for the treatment for all the Medi-Cal enrollees, or do you anticipate there's going to be more?
It was an estimate. I mean, I think that's what we're trying to work through. We have seen, I think we've paid out about $43 million in the recent set of payments through our managed care structure, and we are assuming we'll get more. We have another $43 million that's about to go out in the next couple of weeks. So we're hopeful that it will remain under that amount, but we're seeing increased utilization as we go further through the year.
Thank you. And then the second other set of questions to Mr. Lewis from Unite Here Local 12. Just some clarification on your breakdown. You had said 20% of your overall trend is for your drug pricing, and is that the correct number that you gave me?
A little less than 20%, and I should say that's on a national basis. We have much less transparency in California because of so many people are in managed care organizations. We're making great strides on that issue, as you know, but on a national basis, it's a little under 20%.
And I guess the reason why I ask is you broke it down, the facility fees are 40%, provider fees 25%, so it makes up 85% of your total payments out, but it seemed like 20% is high compared to the national average for drug prices, which is between 9 and 10%. So how is there and why is there that discrepancy for you? I'm not sure how it is for CalPERS or other entities.
Yeah, I can't pinpoint the exact reasons. I think what we've described, what we've heard here about the specialty drugs and the generics, I can echo that. And you know, a related question that came up earlier, we've certainly seen these shadow pricing events, which I don't know that they trigger Justice Department investigations. It's the barriers to entry, even in the pharmaceutical industry, because of the capital cost investments and so forth, they're huge. And so the limited number of manufacturers and providers who are out there, they see their competition raising prices 20% in a day. It's quite easy for them to match that rate the next day.
And then following up on another comment you made with regard to comparing your cost for facilities or hospitalization is 38% higher in Northern California than Southern California. But what I wanted to follow up is something that just was kind of a concern, because obviously my concern also is of market consolidation and how large entities now can dominate the market at increased costs, which, you know, at what point does antitrust and when does government need to step in? But you mentioned something about closed arbitration and antitrust, and, oh, was it you? And I thought I heard somebody from there, and that was of concern, because, you know, I've authored bills in the past that were meant to ensure that hospitals can't use contractual provisions to hide costs for other services. So explain to me what you meant.
So one of the things, so what's happening is Sutter is imposing these on the health plans, and then they're also trying to transfer that to the actual union trust fund. And so one of the things that we said is, I'm sorry, I'm looking at my notes here. Basically, there's a statute in the Health and Safety Code 1375.1, Section D, subsection 1. And Sutter argued they could use these statutes to force us into arbitrate its antitrust claims against Sutter, even though we never consented to the arbitration. We never consented to what they were saying they were trying to force us into. So that's part of our lawsuit, and the statutes have really nothing to do with arbitration. So they were trying to use current existing law to force us into arbitration. We were saying that we never agreed to that. There was no contractual obligation between us and Sutter to agree to these things.
But I'm trying to figure out how the antitrust issue comes in, because antitrust deals with entities that are, collaborating to increase fees to sell to you. How is the antitrust issue with you as a purchaser? I'm trying to
Well, they're trying to use their market leverage. So one of the things that happens, especially in places such as Sacramento, where they control much more of the market, they try to use their market leverage to force us all across Northern California into that same type of agreement. So, you know, it's Sutter trying to use its market dominance in certain regions of the state to then, you know, assert that in the whole part of the state where our Northern California Trust Fund, you know, covers people.
Okay, thank you. Just in closing, I mean, there seems to be kind of a unanimous theme that I'm picking up is, number one, unit cost, especially drugs, but also there's kind of this overriding sentiment that generic drugs as well just seems to be increasing. Facilities, hospitals, obviously market consolidation, these are things I think we need to talk about. Provider fees seem to be kind of at the bottom, at least for the market, obviously not for Medi-Cal. Provider fees are horrible in Medi-Cal. But so this is kind of what I'm hearing, kind of the overriding issues. But the most important issue that I continue to hear, which I heard on the last hearing, is still transparency, whether it's transparency in provider rates, but also now transparency on drug prices, facilities, and now I'm a little concerned about some of the binding arbitration and issues that you'd mentioned with regard to the closed arbitration and the antitrust. So anyway, I appreciate all the comments that were made by all the presenters. We're now going to move on to, thank you very much, we're going to now move on to the third agenda, biomedical industry perspective. We're going to have all three of the presenters come up to the dais. Mr. Greg Alton, Executive Vice President, Corporate and Medical Affairs for Gilead. We have Kendra Martello, Deputy Vice President, Strategic Operation and State Policy for Pharma. Dr. Jeffrey Joyce, Associate Professor, Clinical Pharmacy and Pharmaceutical Economics and Policy at USC. Good afternoon and welcome. And we're going to get started with Mr. Greg Alton. Please proceed.
Chairman, if I could have your permission, we could reverse the order. I think it'll work better for the panelists in terms of our presentations somewhat build off each other.
Well, I mean, we've already announced this. Let's just go ahead and stick with the order. We'll go with Mr. Alton first.
Okay, great. Well, good morning, Chairman Hernandez and Vice Chair Nguyen. My name is Greg Alton, as you announced, from Gilead Sciences, and want to give you a little bit of perspective from the industry today. I want to tell you that I will give you some facts, but also some opinions, and the opinions are my own and not necessarily of the company. So I'd like to start off with a little bit about Gilead and what we do, and there is a point to this that I'll come to. We are a California-based company. We have about 5,000 employees in California, most of them in Foster City, but we also have employees in our manufacturing facilities in Oceanside and San Dimas. At Gilead, our mission is to really transform and simplify the care for people with life-threatening diseases, and really trying to bring through products that end the suffering and improve the lives of those patients. And in doing so, we've helped millions of patients in the U.S. and globally in the area of HIV/AIDS and hepatitis B, hepatitis C, cardiovascular disease, and now oncology most recently. We are very active in terms of continuing to advance the science. We have now 50 compounds in development at Gilead in 150 different clinical trials. And this is really important because we were talking about specialty drugs. Many of these drugs that we have in development would fall in the category of specialty drugs. And they are drugs that are addressing diseases that currently have, many of them, address diseases that currently have no treatment options. And so we do believe that these will add significant value to the healthcare system, both for the patients who will now have a product that can actually treat their disease, to the healthcare system, avoiding long-term costs, but they won't necessarily reduce overall healthcare costs because we're talking about treating a disease that currently we're not treating. So we're not replacing current therapy with what we're trying to do. We're trying to bring new science forward. And we think that's what the industry should be doing. So I think as we think about cost containment, we just want to really emphasize also value and quality in terms of what you're getting for the cost, because I think that's really something that's very important. And I do think it's what we as a company, and we think that as a legislature, you should be trying to provide through this. In terms of HIV/AIDS, I'm just going to talk a little bit about our history there. As I think many of you know, there's about 1 million people in the United States infected with HIV/AIDS. In California, about 135,000. We've been a leader in the development of therapies for HIV and feel that we've transformed the disease. From a disease that about 20 years ago, patients would have to take 20 pills a day with lots of toxicities and would lead to poor adherence and breakthrough. So at that time, AIDS was largely a death sentence. Today, with our therapies, and we have several of these, patients take 1 pill a day, very low toxicities, and can live a long, fairly normal life with HIV/AIDS. So it's remarkable what we've been able to do. We've worked very closely with the California ADAPS, that's the AIDS Drug Assistance Program in California, to make sure that there is access of Californians to our HIV medications. So that's something we're very proud of at Gilead. The other thing that we've been really focusing on in the area of HIV, beyond just providing the drugs and developing the drugs, is making sure that patients get them. I mentioned some of the work we do with the payers, including the AIDS Drug Assistance Programs. We also work in the communities in some of the hard-hit urban areas of California and around the United States to really improve diagnosis of patients, because one of the leading causes of AIDS now, that's when HIV advances, is people are unaware of their status and they're developing full-blown AIDS. And that is a very hard to treat patient and incurs many costs for the system. There are also, those patients are the ones that are leading cause of new infections in the United States, which has not changed in the last 20 years, the low of new infections. So in terms of other work that we do, and we're very proud of it, Gilead, we do a lot of work globally in the area of HIV/AIDS. Most of the AIDS cases in the world are in sub-Saharan Africa, Southeast Asia, and Latin America. And we have a very broad and innovative access model that we're very proud of to provide our products to patients in those markets. It's a no-profit model. It's a humanitarian program. And we're reaching over 7 million patients every single day with that program. There was a reference earlier to some of the pricing in Egypt. We are doing the same thing with hepatitis C, because hepatitis C, like HIV, predominantly infects people in poor countries around the world. And so we want to replicate our humanitarian program for HIV, which has received numerous awards from the U.S. government and from international agencies in hepatitis C. So it's something we're very proud of. So talking about hepatitis C, there's about 200 million people globally with hepatitis C. The official number in the U.S., although there are ranges, and some people show those ranges, is about 3.2 million and about 600,000 Californians. Currently, hepatitis C kills more Americans than HIV/AIDS. That is largely due to the success of the therapies that we have developed for HIV, but because historically we have not had good treatments for hepatitis C. I don't need to go through what the virus is because one of the prior panelists mentioned that, but I do want to mention that it's primarily a disease of baby boomers. About 70% of the people with hepatitis C are over the age of 50, and so it is an aging population. And that's really important to note because the cost of not treating hepatitis C will grow over time, and some of the other panelists will talk about that. It's also a disease that has higher rates in our veteran population, in mothers who had blood transfusions during pregnancy, which was common in the 70s before we actually knew what hepatitis C was, as well as hemophiliacs and intravenous drug users. So I think that gives you a sense of why we've been so focused on hepatitis C at Gilead in terms of our science. We've been working on hepatitis C since the late 90s when I joined Gilead, so it's been a long, long road. At that time, the only treatments available, and this was actually up until just over a year ago, were very toxic, very difficult for the patients with anemia, depression, and flu-like symptoms, really making those patients, those products unacceptable to many patients, and actually not usable by many of the patient populations. We were able to cure, up until the Gilead's innovation came along, about half to 2/3 of the patients who were actually eligible and willing to undergo that type of therapy. And those numbers are actually much lower in Latino and African-American populations that, for a reason we don't know, just did not respond well to the interferon-based regimens. So given these low cure rates, patients just simply would not undergo therapy, and so we had a growing problem. So today, I think it's been talked about the quality of the data we have. We can now cure hepatitis C with 1 pill a day with no interferon that has all the horrible side effects. Most patients without ribavirin, which is another drug that has a lot of the horrible side effects. For about 45% of the patients, we can do that with 8 weeks of therapy. For about another 45% of patients, we can do that with 12 weeks of therapy. And then for a very small number of patients, roughly 10% or so, you actually have to use the therapy for a lot longer. But I want to point out that 10%, which gets you obviously to the higher cost, those are patients that currently, without this therapy, would have no treatment option at all, could not be cured of hepatitis C. So there was no other treatment option for them. So now I'd like to turn and talk a little bit about drug pricing, because I think this came up today, and how we price drugs at Gilead, and I think this actually reflects how the industry prices drugs. So the first thing I want to just say is that we do not price our medicines based on the cost of development or the risk of development. We do not sit down once a drug is developed and say, well, what did it cost to make that drug, or what was the acquisition cost of Pharmaset, what was the risk we took on this, and then have some multiplier and come up with a price. That is not how we do this. It really starts in terms of how we make the investment, the decision to invest in a program to go after a disease. And we'll look at a number of factors. Well, first of all, we look at the science. Are we confident that the science is going to result in a product that will be suitable for treatment of humans? And that actually kind of does go to the risk that we look at in terms of drug development. We'll look at the unmet medical need. Is there a real need for a new drug in this area? And I think one thing that Gilead has been very strong about, and I think the rest of the industry, is we do not want to develop me-too drugs. We want to develop drugs that are addressing a problem that exists that's not currently addressed by the healthcare system. How many patients suffer to this disease? And also, very importantly, will the healthcare system support the value of that therapeutic should we be successful in developing it? That is really what we look at in terms of how we develop drugs. So if successful, our hope is that we will be able to bring that product out to meet that unmet medical need and work with the healthcare systems. So once we complete our clinical trials, we then look at the clinical profile of that product. Does it fit the profile that we were hoping to in developing that drug? Does it have the value to the system that we were hoping for? And then we also look, very importantly, at similar therapies. What is the cost of similar drugs, similar therapies for the particular disease that we're developing? And I want to it's not a simple calculation, but we actually look at a number of drugs in that particular disease area, also outside that disease area. So looking at Sovaldi and Harvoni, which I know is something that people want to really focus on here, we price those really on the clinical benefit of those products, the economic and public health values of those, and really emphasizing on the value of a cure. These are not drugs that patients take for the rest of their lives, like many of the other drugs that were referenced today. Patients take these drugs for 8 weeks, 12 weeks. We cure 95% plus of those patients, and that is it. That is the cost of the system. There's no future cost in treating those drugs with those drugs. I think that's a very important difference when you're talking about a drug like Sovaldi or Harvoni and comparing it to drugs that you have to take annually every year. So I think that's a very important distinction. The other thing I want to point out, when we looked at pricing Sovaldi and Harvoni, we compared it to the cost of the existing regimens that were out on the market at that time. The existing regimens when we launched Sovaldi were $84,000. I'm sorry, about $96,000. That is the cost of Harvoni plus the other drugs you'd have to use, Sovaldi plus the other drugs you'd have to use with Sovaldi. Harvoni, we did the same thing. We priced it at the then current cost of the drugs. Now, I also want to point out, however, the cost of treating hepatitis C with Sovaldi or Harvoni is substantially less than what it cost to treat hepatitis C a year and a half ago. And the reason for that is it's not just drug cost, it's actually what you get for using the drugs. We nearly doubled the cure rate in some populations, in Latinos and African Americans. We substantially increased the cure rate in other populations that use these drugs. And that is the only value that you get for treating hepatitis C, is getting a cure. We also eliminated the burden of managing the side effects for 24 weeks to 48 weeks of using interferon. And some of the studies have shown we actually reduced the cost from roughly $180,000 per cure to roughly $110,000 per cure. So it costs less to cure hepatitis C today than it did. So why the controversy over the price? I think there's a number of reasons for this. And I think that one of the reasons I mentioned this earlier is this is not a Me Too drug. This is not just incremental innovation. This is a breakthrough therapy that's doing something we could not do before. We weren't really paying for hepatitis C treatment a year and a half ago because the treatment was so horrible. So now we have these new fantastic drugs, Sovaldi and Harvoni, and AbbVie has now come out with their own drug that's fantastic. And now we can treat the people that have hepatitis C. That was a cost that we did not have before. It's a new cost. And that's what happens when you have innovative breakthroughs like Sovaldi and Harvoni. But we want to really emphasize the other challenge of this is the costs are all up front. You're not paying year by year by year by year for these patients. You pay it one time and you're done. With most of the other drugs that we're used to and our healthcare system is used to, you pay for it every single year for the life of that patient for chronic diseases. So this is very different. It's really a game changer in terms of what we can do. So if you look at drugs, and some of these were mentioned, or diseases, HIV, rheumatoid arthritis, MS, diseases like that, if you actually look at the real cost of treating those drugs, not just the price of the medicines, the cost of treating those diseases, it costs more than treating hepatitis C today. So the idea that this is a large population and we've never seen prices like this before is only looking at the price of the drug, not the cost of actually treating the disease. So I think that's really important. So in terms of the challenges to the healthcare system, we really need to look at how we value cures and how we pay for cures, because that is really what we want. We don't want to treat chronic disease. We want to cure chronic disease. We want to make people better. We don't want to just alleviate the symptoms. We don't want to suppress virus. We want to eliminate virus from them. So the other thing I think that's really important to point out is we need to be realistic about the patient flow. We think there's significant value in curing hepatitis C. We also need to be realistic about how many patients are going to come through over time. The most aggressive study done was by the NIH, the National Institutes of Health, who said if there were no budget constraints and we had all the funding to treat hepatitis C, it would take over 10 years to cure all the Americans of hepatitis C. So numbers being thrown around like 300 million or 300 billion, that's just not going to happen in a short period of time. This is going to be a long, drawn-out process. Our experience in HIV, getting undiagnosed people, which is about 2/3 of the hepatitis C population, is going to take a lot of time. This is not going to happen overnight. So if you think about the budget implications of this, it's not as if we're going to be treating all these people overnight. However, once we do treat these people, they are no longer infected with hepatitis C, so we no longer have to treat them. I also want to comment a little bit on pricing, because I think the U.S. Healthcare system is the most unique in the world in terms of how we price products. So a lot of people have thrown out the price of $1,000 per pill. That is the price that we launched Sovaldi at. Harvoni is actually a little bit higher than that. That is wholesale acquisition costs. That is not what most payers pay for hepatitis C treatment. That is the list price that we come out with, and then we negotiate off that through rebates and other discounts into the system. Medicaid gets an automatic 23% discount. We provide voluntary discounts on top of that to Medicaids, and we negotiate for expansion of the treatable population to do that. We negotiate with the VA in terms of their pricing as well as other payers. And in terms of what that has meant to the pricing, our prices in 2014, if you add up the rebates and fees that we pay, you'd have to reduce that by about 22% across the board for our hepatitis C products. Now, a comment came up that competition isn't working, that AbbVie now has launched a competing product, and that has no impact. Well, we actually just announced yesterday what our estimate is of that same discount and fees for 2015, and it's going to be about 46%. So we actually think that is competition. Those are real numbers. So we actually are seeing a competitive dynamic now occurring between AbbVie with their hepatitis C cure, Gilead with our hepatitis C cure, that is actually now reducing that wholesale acquisition cost substantially. The public payers, that same number is going to be over 50% this year, we anticipate, in terms of what the cost is. And so I think there was some talk about what the prices are in the U.S. versus Europe. The challenge in the U.S. is there's not one price. There are multiple prices. We have VA prices, we have FSS prices, that's Federal Supply Schedule, which is Department of Corrections and Indian Health Services. We have Medicaid prices, which are different. We have Medicare prices, and we have private prices. There's not one price. But if you took that blend of discounting and different price in the U.S., you're going to get much closer to the European price. I'm not going to say that we're going to be less than the European price, but you cannot just compare WAC prices, wholesale acquisition costs, to what the stated prices are in Europe. That's just not factually correct to do that.
If you don't mind, I apologize. Each speaker was given 10 minutes.
Oh, I'm
We're
sorry.
at 15 for you. All the other presenters were at or below 10 minutes. So if I can ask you just to summarize.
I will just wrap up, and I'm sure there'll be more questions. So
Right.
yeah, I think what we're really saying is, we really want to focus on quality and value, and I think that when you think about cost, you also need to think about what you're getting. And we think that, yes, I will not say that the price of Sovaldi and Harvoni is inexpensive. These are expensive drugs, but we think that the value justifies it. We think these are incredibly valuable interventions for our healthcare system.
Thank you very much.